Good afternoon, everyone. So I think we all realize having a good sleep, a restorative sleep, is good for weight management. But what I would like to talk about and focus this session on is really talking about people with obstructive sleep apnea. They're clearly a group of patients that don't have restorative sleep. They're chronically sleep deprived. And because we've been sitting here a while, and just to get a little bit of our audience participation, how many people either know or have a family member or know someone with obstructive sleep apnea? Raise their hand really high since so look around the room. So it's more than half. But obstructive sleep apnea is a sleep disorder. It can be obstructive where the upper airway closes, central or mixed. It's very common, as we can see, with a show of hands even in this audience, but the incidence starts in the 40s and continues with each decade of life. More common in men and as well as in African Americans. And the severity is based on the Apnea Hypopnea Index, or AHI, which is just how many times you stop breathing or have a partial narrowing of your airway each hour. And so very mild would be maybe 5 or 10, up to more severe where you could have someone having closures up to 60 times an hour. So every time you have an apneic episode, patients tend to have these microarousals. They wake up a little bit, they breathe a couple normal breaths, and then they fall back to sleep. So you can see in the severe patients with sleep apnea, they don't get any form of restorative sleep. And it's considered treatable, but fairly unrecognized and undertreated in the US. And people are at increased risk for cardiovascular morbidity and mortality. And really over my career, I've been looking at, with others, the mechanisms why people with sleep apnea are increased risk for cardiovascular disease. And as it relates, what factor obesity has on risk for cardiovascular morbidity and mortality. But obesity is common in sleep apnea. And we know that if you gain weight, it makes sleep apnea worse. So just to go a little over some of the characteristics. Usually this is kind of the hallmark. It's repetitive apneic episodes. Often a bed partner will witness someone asleep and not breathing. This has happened to me on the airplane, and this is the terrible thing to do because someone falls asleep beside me and they stop breathing. And so you have to have this conversation when they actually wake up to see, do you have sleep apnea? The other common characteristics is obesity, but not all of our patients with severe sleep apnea are obese. 90 million people snore, and about 25 million people have sleep apnea. Just because you snore, you don't have sleep apnea. Large neck circumference, family history, daytime tiredness, and hypertension. And sleep apnea is a recognized independent risk factor for the development of hypertension. And if you have uncontrolled hypertension or untreated, the hypertension is very often resistant to drug therapy. One that's not listed on this is just something that comes up sometimes in the clinic is someone has bruises along their upper arm and their leg. Can anyone guess why that would be? Their bed partner every time they stop breathing or they get kicked. And one poor fellow had bruises from his shoulders always down to his ankles. But I just leave this kind of picture up there for everyone to try to remember these characteristics, and those become important. But typically male, middle-aged, falling asleep. This patient was in the waiting room, and large neck circumference. So we can treat it either with nasal CPAP, and that's the figure on the top right there, just produces a positive pressure column in the upper airway while you sleep to keep your upper airway open. There's surgery, dental devices that push your lower jaw forward, some hold your tongue, avoiding drugs that worsen sleep apnea. Weight management, decreasing weight actually improves severity of sleep apnea. And some people just have sleep apnea, for example, on their backs. So there's some therapy that try to keep you on your side while you sleep. So let's focus on obesity and sleep apnea. We know that weight loss is much more difficult if you have untreated sleep apnea. So the number of trials that have shown diet and exercise, if you go back and look to see why people didn't get a good result in those trials, they can have unrecognized sleep apnea. But if you think about it, if you don't have a good sleep during the day, you're tired, you have decreased physical activity, and that might be a reason why sleep apnea also causes weight gain. And we observed clinically that patients are often obese and have weight gain. But the real question became, when we first looked at this, does sleep apnea predispose to weight gain? So does sleep apnea itself? And one of the colleagues that I worked with, Varen Summers, he thought of the following schematic, and that's on the right, that he showed that people with sleep apnea have increased sympathetic nerve activity. And that might, because of that increased nerve activity, might cause the adipocyte to produce less leptin, and the sighting of low leptin might be one reason for the weight gain. And so this is one of Varen Summers' first studies he did. And on the bottom panel, maybe look at the line that says respiration. And as you can see there, it says OSA, obstructive sleep apnea. There's periods of 30-second to almost a minute of obstructive sleep apnea. So this is recordings when one person was asleep in the slide. And then if you look at the SNA, or the sympathetic nerve activity, just on top, with the prolonged apneic episode, you see much higher nerve activity or sympathetic activity, and this was measured using microneurography. So every bump or burst, you can measure bursts and the amplitude of the burst over 1 minute. And as you can see, with apneic episodes, you have a much increase in sympathetic nerve activity. You have a couple of normal breaths, and then sympathetic nerve activity is decreased. With that, in the bottom panel, you have surges in blood pressure. Blood pressure systolic can go over 200, and the bottom number, the diastolic, can go up as 110. So the important point is that when people sleep, they have high sympathetic nerve activity, and it's correlated with their apneic episodes. So in the lab, we wanted to know, does this sympathetic nerve activation also occur during the day when people are with sleep apnea are breathing normally and not sleeping? The study was done by Christoph Narkowitz in the lab. He was a postdoc, and he looked at a number of normal weight on the left, obese, and people with sleep apnea, and showed that even during the day, when people with sleep apnea were breathing normally and not sleeping, they had increases in their sympathetic nerve activity. And this was much higher than obese controls who we took to the lab. They didn't have sleep apnea, and of course, higher than normal weight patients. So the other clinical observation we made was that when people came to the sleep lab, a lot of them complained about weight gain. And this was done by one of my students. We looked at weight histories, people coming to the sleep lab for both males and females. In the white are people with sleep apnea, and in the black were controls. And if you look at either male or female, people with OSA had, for women, almost an 8-kilo weight gain the year prior to being diagnosed with a sleep apnea, and it was a little over 6 for males. And again, these were matched for age and percent body fat. So we have clinical evidence that people complained about gaining weight with sleep apnea, and compared to those that didn't have sleep apnea. And Varen showed that they shouldn't be gaining weight. They should have less leptin. They have high sympathetic nerve activity. So what's going on? So we did a follow-up study, and this is just in men. We looked at 32 patients with sleep apnea and controls. They are matched for age, percent fat, and people with sleep apnea, their AHI was 44. So this is moderate to severe sleep apnea. And their nerve activity, the muscle MSNA, was 46, and that was significantly higher than the controls. What we saw was the weight change was 5 kilos on the right there, that they gained more weight over the year compared to the controls. But what we thought was leptin was going to be a lot lower in sleep apneics, and this was one of my favorite studies because even based on the physiology, you get something completely different than what you anticipate. And on the left, it shows that people with sleep apnea had a much higher leptin level, even in an environment where the nerve activity should decrease leptin release compared to controls. So this paper really showed that sleep apneics have higher leptin resistance than obese patients that were free of sleep disordered breathing, and might be a reason why they gain weight and have a very difficult time losing weight as well. So we explored this a little further. One of the postdocs infused isoproterenol in obese and lean patients, and he's working on patients with sleep apnea. In the left panel, these are lean. In the open circles, it's just infusing saline over 4 hours, and the black circles are isoproterenol to increase heart rate by 20%, and then looking to see what leptin does over the subsequent 4 hours. And on the right side, it's obese. Again, in the clear or open circles, it's just saline, and starting in the day, what leptin does. And you can see between obese and a lean, if you give isoproterenol, which is just a beta agonist, the lean have about a 20% maximum decrease in their leptin, and obese patients, it's about 11, so about half. And if you look at area under the curve, the effect curve, it's much smaller for obese patients than it is for lean. So there's clearly something going on in obesity in signaling leptin. All right. So to try to leave you with kind of a take-home message, hopefully everyone will recognize and appreciate that untreated, unrecognized sleep apnea may lead to weight gain. It's very difficult for them to lose weight if they don't have their sleep apnea treated appropriately. Some of it may be because they're just tired during the day. They can't exercise, they have cognitive impairment, and that might be some reason. But I think I've showed you that patients with sleep apnea, there might be more of a physiologic reason why they also can't, or why they gain weight, and it would be hard for them to lose weight as well. So if you take home anything this evening, just consider that sleep apnea is a preventable barrier to diet and exercise strategies and weight loss and management. If you think about the prevention, sleep apnea worsens with obesity. We showed that there is significant weight gain that occurs in sleep apnea. So if you recognize it early, you might be able to prevent some of the weight gain that occurs. If there's weight gain, severity of sleep apnea will increase, and so it's just a vicious cycle. There's some comments that were made earlier on today about children. It's not my area, but the instance and what we're seeing in children is sleep apnea is getting more common, I think mainly because children become more obese. Unlike adults, kids don't get tired during the day. Like my children, and your children, if they lose sleep during the night or don't get a good sleep, what are they in the morning? Hyperactive, right? So some of the ADHD in kids sometimes is being misdiagnosed, and really they have untreated sleep apnea. So keep in mind the common characteristics. This should raise your suspicion. Does your patient or does your study subject have sleep apnea? These are all common characteristics. Again, the hallmark is gasping at night or witnessed apneic episode. There's also a fairly standardized questionnaire. You can actually Google Berlin Questionnaire, and this comes up. It identifies people at low risk or high risk, and it's a series of questions about how often you fall asleep, kind of your snoring, as well as do you have hypertension or obesity. So in conclusion, sleep apnea is relatively common in middle age and increases with age. Obesity definitely worsens sleep apnea. And we showed the corollary to this, that sleep apnea predisposes to obesity and contributes to cardiovascular disease. And if we can recognize it early and see it as a preventable barrier, I think this is key, particularly for the focus of this conference, that if you can treat it, then you have better chance of losing weight and sticking to diet and exercise strategies to lose or maintain weight. And so please, if you could give some thought to recognizing the treatment of sleep apnea may help prevent weight gain and help with weight management. And with that, I'll take any questions.
Yes. I particularly liked your talk because this is what I was saying in the morning. This Nick Durand said in the morning, that if there are contributors to obesity, they need to be treated and to have a cause-specific treatment. If untreated, and if you focus only on diet and exercise in a particular person who has sleep apnea and not treat sleep apnea, that may not yield results. So I particularly liked your presentation. But my question was, once a person is diagnosed with sleep apnea and they start wearing CPAP, does that change the trajectory of their weight gain, or do they lose weight?
Well, so if the question is, what happens when you treat sleep apnea? So there's been a number of studies to show that when you treat sleep apnea, muscle sympathetic nerve activity decreases or normalizes. And actually, there's a number of studies to show that leptin levels decrease as well. But the studies are mixed. There's a few studies that show that maybe percent fat doesn't change with treatment, and sometimes there's a couple of studies that show that visceral fat changes with CPAP therapy. And one study did show that if you were very adherent with CPAP, weight actually went up. So it really comes down to, there's a mix of studies. I think I've seen some very good studies to show that people definitely have better cognitive function after they get treated. They feel a breath of fresh air. They're more apt to feel better during the day and hopefully maintain more or be open to doing diet and exercise. And other thing to consider is how long they've had sleep apnea. This might be one of the confounding variables on the effect of not only treating someone with CPAP therapy or alleviating sleep disorder. Do you remove their cardiovascular risk? Do you remove, or is it a reversible or irreversible effect on the weight that they've gained? So I think those are kind of questions that still remain to be answered.
I'm a pediatrician, and I can tell you that at our children's hospital, most of our children with sleep apnea are not obese. And I think that it creates a really nice experiment, actually, to understand these mechanisms. So I'm curious about two things. Are there adults who have sleep apnea who are not obese, in whom you could continue to do this type of work and look mechanistically at the differences? And then secondly, if you are hypoxic, you're affecting your mitochondria and your ability to generate ATP and energy. And so I'm curious if you've connected this with mitochondrial activity as well.
Yeah. So in children, sometimes it's mostly anatomical, big tonsils, that kind of thing, or sometimes if they gain weight, if they put weight around their neck, that can affect prevalence or incidence of sleep apnea. So we have studied lean adults. There are lean adults. They're very hard to find, particularly with severe sleep apnea. So some of the studies we've shown that even in lean sleep apneics, they have some of the same kind of responses, even though they're lean. And I didn't show that data. And then as far as the effect of the environment of sleep apnea has on metabolic rate and that kind of thing, we've done some of those studies and others have done those studies. So there is a interaction between severity of sleep apnea, kind of basal metabolic rate as well.
So I had a question about the leptin study. So when you showed those elevations in leptin and the leptin resistance, those were in patients that had already been identified with the sleep apnea. If you caught patients at the early stages, at that point, do you think you might see differences in leptin levels? Because obviously there's this sort of inverted U-shaped curve as it relates to how leptin gets across the blood-brain barrier and leptin resistance and so forth.
Yeah. That's an interesting question, and quite often our patients will have sleep apnea for years, and they think this is just the normal way of life. So I'm not quite sure I've seen any study to really catch sleep apnea, because it's very hard to ask patients, well, how long have you had sleep apnea? And quite often it says, well, this is how I've always felt. It's usually kind of a slow kind of onset, and they're just used to that type of environment. We're all tired during the day, and you kind of work through it. So I usually try to look through the audience to see if anyone nods off. And it's not because I'm a boring speaker. I'm saying, well, they just have sleep apnea. But I think that's it's interesting. I think it would be very difficult to address in humans. All right, thank you so much.